Hey, did you want me?
No, sir. I was just letting you in the room.
Oh, thank you, Zabaya. I never get a chance. Thank you for everything you do.
Absolutely, sir. Absolutely. Hold on, please.
Who's that?
Sure.
Yes, it is.
Hi, everybody who's on here so far. Just bear with us a few minutes. We had to start early because we're trying to iron out some technical difficulties. So thank you so much for being here. We'll be getting started in a few minutes here.
Hey, Carly. Hello, Miss Sawaya.
Hello, hello.
Hi.
Yay. Okay, I got it, Sawaya. Thank you.
Okay, you're welcome.
Is that you, John? With the picture of the cute puppy?
Oh,
Yeah, that's Henry. That's
oh
my
my gosh, I
my
love
dog at home.
him.
Yeah, he's a golden doodle.
Oh.
I'm cold today for some reason. Don't know why.
It's freezing in my office all the time, no matter what. All right, I see people coming in. Very exciting, fabulous. Like if anyone was not here when I said earlier, we started a few minutes early to try and smooth out some technical difficulties. So I'm still going to wait until about 6 o'clock in 2 minutes to really get started. But thank you all for joining us. So bear with us while we're just waiting for everything to get started up. Hold on 1 second, so I've somehow gotten my Zoom out of full screen and can't get it back. I see the virtual conference, like the welcome page up, so that's good.
Oh, I started sharing my screen. Is that what everyone's seeing?
Okay. That's what Zoya is asking. I'm just
Should I unshare?
I can't well, I can't get my Zoom back to full screen.
Yes, Dr. Chen, if you could unshare, because we're gonna actually complete a poll in the beginning. And we're just gonna welcome everyone and complete a poll, and then you can start sharing
Oh, okay.
your
All right.
presentation. Okay, thank you.
Now it's sorry, just fix the issue. Thank you for helping. All right, I've gotten my screen back to full screen so I can see everything now. And it is 6 o'clock, so I know we'll get rolling here in a few minutes. Thank you, Dr. Cheng. Am I supposed to be seeing, do you have the slides up right now?
I do not have them up right now.
Okay.
I'm getting ready to put them up right now.
Okay, good, good, good. We've got a lot of people here tonight. And
Oh,
this
great.
is, I know, I was gonna say, Dr. Chen, this is one of the higher attended live seminars so far, so lucky you.
Yeah.
But the pressure's on.
Yeah.
I think everyone's very interested in this, hopefully. So it's very exciting.
Well, hopefully they're still interested when I'm done. That's
They will be. And just want to give it a few more minutes. I know some people come on a little bit late. I want to give them time, and then we're going to get started soon, everybody. Thank you for your patience.
I'm gonna stop sharing and let everyone in.
Okay.
All right. Good group.
Mm-hmm. Are there still more people coming in, Zawaya? You think that's
Yes, I'm actually letting everyone in now. I'm gonna go ahead and start sharing.
okay?
And then go from there.
Awesome. Thank you.
So we've completed the staring contest portion of the evening, huh?
Exactly.
All right.
I don't know who won though.
Yeah.
All right, good. So people are still coming in. Thank you to everybody. Just while we're waiting, let me say hi and introduce some of the people that you see on here tonight. So my name's Carly Lucas. I'm one of the board members for BIAD. Very excited to be here. Very happy that you all have joined us tonight. So let me talk about some of the other people that are here, people that have been totally instrumental in making this virtual conference a success. Let's see. So we've got our corporate board president, Dr. Terry Harrison Goldman. She also serves as the co-chair of the conference planning committee and the co-chair of the grants and fundraising committee. I don't think, was Steph on here? I don't know. Steph is on here. So Miss Steph Lancaster is the vice president of the corporate board, also the co-chair of the conference planning committee. We've got our executive administrative assistant, Zawaya McElrath. We love her so much. She has done so much to put this all together for us. She's also helping us with all the technology needs. I'll talk a little bit more about some of the tech stuff later, but if you're having tech issues, send Zawaya a little message. She's the one who's taking care of all of that. So I am, like I said, I'm Carly Lucas. I work for Delaware Elder Law Center. We help families that are managing the care of a loved one. And I'm the co-chair of the Events and Communications Committee. So I'm very happy to be your host tonight for our 4th educational webinar in the virtual conference series. And if you missed last week or any of the other weeks, all of the recordings are online on our website, biad.org. They're also on our YouTube channel, I believe, so you can access them still that way. So with that all being said, welcome to session 4. We're so excited. We're happy everyone's here tonight and taking advantage of the live portion of the seminar. We think still more people even are going to be taking advantage of the on-demand videos later, so people can still catch all of this information. You can share this with anyone you'd like. This is really valuable information. You can share with your friends and family and your colleagues. So let's see, if you want to go to the next slide, Sawaya, I think we're going to be launching the poll soon. So our lovely Steph was going to be your moderator tonight. We're having some tech problems, and so you saw Steph's picture there. We love her. All right, so Zawaya is going to launch a poll. So we want to see everyone who's joining the webinar tonight, everyone who's in the room with us tonight. So that's going to come up in a second, and you can choose the category that best describes you, your connection to the brain injury community. That'll come up momentarily. You know what, I'll go back to, let me thank everybody before the poll comes up. Do you want to go back a few slides, I'm sorry. Perfect. Okay. Our board members, our fabulous and wonderful corporate board members and the BIAD advisory board members, they've all given so much dedication and support. They've given their time to this, to BIAD. They're a very impressive talent, their money. They've given a lot to support the work that BIAD's doing in the community. So big thank you to everybody. Let's see. I also want to thank specifically the virtual conference planning committee. They've worked so hard to make this all happen and make this virtual event a reality. All right. Thank you to all of our sponsors this year for their support of the virtual conference webinar. We've got Del One, Federal Credit Union, Encompass Health Middletown, Post-Acute Medical, PAM Health Dover, Bay Health, and we've also got our Friends of BIAD sponsors, Christiana Care Health Systems and Delaware Elder Law Center. And we could not do all of this without our awesome sponsors. So thank you all so much, and we appreciate you. Big shout out to our luncheon on the 31st, on Friday the 31st. Thanks to our sponsors, we're able to put on this first annual Survivor Caregiver Celebration and Community Awards Luncheon. So that's going to wrap up our Brain Injury Awareness Month. So this event is going to be on Friday, March 31st from 11 a.m. Registration starts at 10:30 and it'll go until about 2 p.m. It's going to be at the Harrington Volunteer Fire Company. That is at 20 Clark Street in Harrington, Delaware. Harrington Volunteer Fire Company, 20 Clark Street. So survivors and 2 caregivers are invited to join free of charge, and any community members, professionals, the tickets are $25. You can reach out to us at admin@biad.org if you'd like to register or purchase a ticket. And this is going to be really great. We're very excited about this. So you can reach on out, email Zawaya admin@biad.org to purchase or register a ticket. Now I want to turn it over to Zawaya. She's going to share some helpful hints to help maximize this webinar experience. Zawaya?
First, Zawaya is going to unmute, and then she's
Okay.
going to talk. So I want to say that today's session is being recorded, and it will be available for viewing post-conference. And we encourage you to share these links in your personal and your professional networks. If you have any questions for the presenters and for Dr. Cheng, or for the moderator, for Carly, you can type them in the Q&A section. Questions will be monitored and collected throughout the presentation. All questions will be answered at the end of the presentation to allow Dr. Cheng to present in a uniform manner and for everyone to gather the information that he is going to share. If you have any technical questions or any technical challenges or problems, please reach out using the Q&A section. We have disabled the chat function, so it will not work. And for the best conference experience, I do ask that you please use a laptop or a desktop computer. If you're using a handheld device, some of the features may be disabled and you will not be able to have the full experience. And if you would like to turn on your closed caption feature, feel free. You can click the CC button on the bottom of your screen, and it will turn on your closed caption. And I will be sending out a follow-up email at the end of the session with helpful links and also with Dr. Chen's presentation. I will also send information on the upcoming BIAD events that are planned for the month of March as we are celebrating and honoring the Brain Injury Awareness Month. And for those of you who are taking advantage of the CEUs we are offering, please note that you must watch all 5 sessions to receive the 5 CEU credits. And at the end of each session, a code will be provided. So at the end of this session, I will be providing another code, and you send an email to admin@biad.org with the code that I will provide at the end. And then at that point, I will send you an assessment form for you to complete. And once all of the assessments are completed, you will receive your CEU certificate via email. And all BIAD professional members are eligible to take advantage of the CEUs offered at no cost. Any non-members will need to pay for the CEUs or become a BIAD professional member. And please reach out to admin@biad.org if you have any questions about membership. And right now I am going to go ahead and launch the poll, and then we will go and present. Dr. Chen will be presenting.
Thank you. Okay, so here's some different options. Just pick the one that makes the most sense for you, that best represents your connection to the brain injury community. We like to see who's all joining, who's here tonight. And in a minute or so, I think it's going to show us all the results. The results come right back up. So why, once they're all done, or just that at the end?
So it's going to come up. We have 13 participants that are on the call right now, and we have 9 people have participated. So if we can just have a few more people to answer, it will populate. Okay, the numbers are going up. We're at 11%, so that's 84%. 84% have participated. Okay, I'm going to go ahead and end the poll, and I am going to share the results.
Hey. Fabulous. So our highest attended category is survivors, which I love to see. Thank you all so much for being here. We've got a lot of family members, friends. Well, we've got one at least. The next highest is the speech therapists, service provider organization employees. We've got government employees, physicians, social workers, family members and friends of a person with the brain injury or other disability. So that is awesome to see. Thank you all for participating. Thank you for being here. So, all right, with that, let me introduce our presenter for tonight, Dr. John Cheng. And Dr. Cheng is a board certified physiatrist, physical medicine and rehabilitation physician who joined the Christiana Care Health System in 2018. He obtained his undergraduate education at University of Maryland, College Park, and a master's degree in physiology and biophysics at Georgetown University before working in malaria vaccine research at the National Institutes of Health. He went on to complete his medical education at the University of Maryland School of Medicine, where he was the president of the school's chapter of the Asian Pacific American Medical Student Association, and he served on the admissions committee. His preliminary year internal medicine training was done at Washington Hospital Center in Washington, D.C. Then he moved to Philadelphia for his PM&R residency at the Thomas Jefferson University Hospital McGee Rehabilitation Hospital program, where he served as the program development chief resident. And he's currently serving as the medical director of the Center for Rehabilitation at Wilmington Hospital, which is a 26-bed general acute inpatient rehabilitation unit. He joined the Brain Injury Association of Delaware in September 2022, and he's a member of the advocacy committee. So if that's not enough to tell you how much this man knows about what he's talking about, I don't know what is. I'm very excited, and I'll hand it over to Dr. Cheng. Thank you so much.
Thanks so much, Carly. It sounds better when you read it. Okay, let me share my screen here and we can get going a little bit. All right. Can everyone see now what we're talking about tonight? All right. So again,
Yes.
thank you very much. I really appreciate Bayad for inviting me and having me here to participate in the virtual conference series. Tonight, we're talking about the post-concussion syndrome. Again, my name is Dr. Cheng. I'm from Christiana. So to start, so I have no financial conflicts of interest. I am a board member of Bayad, but do not receive any sort of financial compensation. All right, so objectives of the talk. So I would like to talk about post-concussive syndrome in these 5 areas. So first off, I want to talk about the characteristics. What is post-concussive syndrome? So the signs, the symptoms, just how do you describe it? Once we know a little bit about it, then let's talk about the treatment. And in particular, what are the differences between treating an acute concussion and post-concussion syndrome? Because there are notable differences. Who does the treatment? So I want to talk about the team. I want to mention who the members of the multidisciplinary team are, because each member is critically important to the success of the treatments. And speaking of success, talking about outcomes. What are some of the outcomes that we see and what we hope for through the treatment of post-concussion syndrome? And part of the outcomes depends upon utilization of community resources, and that is something that I'll discuss a little bit at the end. So in order to talk about post-concussion syndrome, we have to talk about concussion first. And so a concussion, according to the American Association of Neurological Surgeons, is an injury to the brain, results in temporary loss of normal brain function. So in general, it's a clinical syndrome characterized by immediate and importantly transient alteration in brain function. And so this includes alteration of mental status, level of consciousness, different initial aspects that with an injury that comes from a mechanical force or trauma. Now, this isn't a bad definition. More recently, there's been some tweaking to this definition, and right now, one of the most commonly referenced definitions describes concussion as a brain injury induced by direct or indirect, that's important, biomechanical force transmitted to the head, which results in a reversible clinical syndrome with signs and symptoms that affect multiple domains, including the physical, cognitive, emotional, and sleep areas. And importantly, concussion reflects a predominantly functional rather than a structural injury. And we'll talk about that as we go through. So Dr. Harrison Goldman last week mentioned there are myriad classifications of brain injury, concussion, and how do we really define it? Well, depending on what resource you're looking at, you're going to find a different definition. What I have on the screen here for you is a chart that's made by the CDC that breaks TBIs down into mild, moderate, and severe. Now, concussion in general falls under the mild TBI category, and some even want to get rid of the word concussion and just use mild TBI as the definition. And so you see there's some criteria here that involve the duration of loss of consciousness, duration of post-traumatic amnesia, what was the initial Glasgow coma score. We see that, of course, as you go mild, moderate to severe, these durations prolong and the coma score gets lower. But in order to really define a mild TBI, you're looking for a GCS from 13 to 15. Now, there is a difference in of course, initial presentation, but also in long-term outcome between GCS scores of 13 and 15. And that's something that we're learning more about. All right, so in general, what is a concussion? So from the clinical standpoint, when you're seeing a patient in front of you who says, I have a concussion, what are the domains, or what symptoms are they experiencing? So the usual categories, and I say usual because not every patient has these symptoms, right? What have we said before? If you see one brain injury, you've seen one brain injury, right? So true. But in general, the kind of areas you're looking at are the thinking, mood, sleep, vision, balance, and feeling. And within these, there are certain symptoms that patients often complain about. And some of these are confusion, headache, vision disturbances, including double or blurry vision, dizziness or imbalance, falls, nausea or vomiting, memory loss, ringing in the ears, difficulty concentrating and thinking, certainly photophobia or sensitivity to light, phonophobia, sensitivity to sound. Sometimes loss of smell or taste can accompany a concussion. You don't always have COVID if you lose your smell or taste. And then trouble falling asleep or staying asleep, or sleeping too much, really. So when we look at the clinical side, what we're learning more about now is what happens on a microscopic level in a concussion. Now, this slide may be a little bit dry, but anyway, just bear with me. So what happens in a concussion is that there are acute neurometabolic changes that happen within the brain. And so, like we said, it doesn't, the head injury can be direct or indirect, as long as it's causing some sort of acceleration and deceleration of the brain. And so what occurs during that acceleration and deceleration moment is that there is a rotational component. There's there's movement of the brain in different directions because the brain is bathed in cerebrospinal fluid, and so it's free to kind of swim in the skull. When there's a rapid change in movement in the brain, there's a shearing force and a stretching force that can cause damage to kind of the membranes of some of the neurons. This damage results in something called mechanoporation. So little holes form in the membranes, and different neurotransmitters and substances can either be released out or brought into the neuron. The net result of all of these things is that there is cell damage and there are energy deficits in certain areas of the brain. And so glutamate is one of these neurotransmitters that gets released from the injured neuron. What it results in is a rapid depolarization of that neuron. And so all these neurons that are in the injured area, they rapidly depolarize or they rapidly fire. And so this creates a high metabolic demand, which the brain can't meet. There's sodium and calcium that enter the cell, and these can cause damage to the cell. They can injure the mitochondria, which are the energy producing centers of the neurons. There's also injury to the interneurons, which are the connections between some of the neurons. And these primarily work to inhibit or slow down some of the firing of adjacent neurons if they're not needed to fire. Now, injury to these interneurons causes hyperexcitability or over firing of the neurons. This theme of rapid and uncontrolled depolarization. Potassium is a super important neurotransmitter. And so what happens with glutamate release is that, and with the mechanoporation, is you get tons of potassium that leaves the neuron. Having a dearth of potassium inside the neurons, you're changing the concentrations. It interferes with how the nerve can fire. It actually creates a feedback loop that potentiates this process, which is certainly damaging to the cell and the ability to function. Calcium, as I mentioned before, is brought into the neuron, and it can cause damage when it's in those concentrations inside the cell. Glucose, of course, is so important. It's a building block of energy in the body. In a concussion, there's increased glycolysis. So there's initial release of glucose. There's a lot of metabolic demand initially, and then there's decrease in metabolism and decreased energy production. If those neurons don't have energy, they can't respond when you need them to do something. There is some levels, there's some research on this showing that there's some region specificity. So areas of the brain that are affected more by these injuries, and also time dependent. So it's not all at once. There's some staging of time. Some of these processes happen more quickly, and some happen over a period of time. There's also something I found interesting is that there are mutations in certain genes that individuals have, which can cause increased symptoms in that person or prolonged recovery in that person. So we're learning a lot more about what makes someone susceptible. Why does this person have is it the wind blows hard and they have a concussion, or someone is tackled by 300-pound linemen and they're fine. So this slide is meant to, I probably should have just written it out. Anyway, it's meant to describe a process called neurovascular coupling. And so the light bulb is the neuron or the nerve. And then on the left side, the red blood cells are the blood supply. Blood means oxygen. And so what happens in concussion, and likewise down the line in post-concussion, is neurovascular coupling dysfunction. And so what results is a cerebral blood flow dysregulation, meaning there's not enough blood carrying oxygen to that nerve, that neuron, when it needs it. And so there are different studies that have shown this phenomenon. And in rat models, it's sad, but anyway, they do these things. They showed actually that the junctions between the red blood cell and the neuron were decreased, and also the length of the blood vessels was decreased in repeated head injury. In a study of athletes with mild TBI or with concussion, they looked at them using different MRI modalities in the first week post-injury. And what they showed was that there was decreased cerebral blood flow, and particularly in the frontal and temporal lobes. And so these regions are involved in autonomic regulation and emotion processing, which is a lot of what we do see in both acute concussion and in post-concussion. So in general, I could say there are actually many other processes that occur in concussion, and we're learning more and more and more about it. So some of these processes are axonal cytoskeletal injury. There's impaired synaptic plasticity. And so this is talking about the junction between neurons and the ability of the body to increase that robustness so that junction can fire faster, fire longer, if we're using that area of the brain more. But in concussion, it's been shown that there's that adaptation has been impaired. There's also neuroinflammation, releases cytokines that cause damage to the neurons and the surrounding area. There's also blood-brain barrier dysfunction. Now, I couldn't really find what caused, directly what damage that causes. That's something we're learning about, but it has been shown. And then cell death. Now, cell death is usually more of a characteristic of moderate or severe TBI. And that can be seen down the line in CT scans and MRI showing decreased brain volume. Usually concussion, or as a mild TBI, for the most part, I don't know if you remember the definitions, a lot of it said temporary, a lot of it said reversible. And so what that comes about from is from cell damage rather than death, and relies upon the body's ability to repair some of these cells and to compensate for the loss of function. So just some numbers. So there's a super wide range of concussion numbers out there, from the hundreds of thousands to even 3.8 million. And this number here was quoted multiple times in the literature, but and is specifically related to sports and recreation. Now, what the true prevalence and incidence of concussion is, we don't really know. It's probably underreported. Most of the data is from the emergency department. Not everyone goes. Most commonly, we see concussions in the younger population, in juveniles, adolescents, youths, and in the more aged population, over 75. Now, importantly, 90% of patients with concussion symptoms get better within 10 to 14 days. So 90% of those symptoms resolve within a 2-week period. And that's important to remember. All right, so what are some characteristics? So in practicing for this talk, I said post-concussion syndrome about 5,000 times, and my throat was dry. So I think I might say post-concussion syndrome, I might say PCS, I might say PPCS, which is persistent post-concussion syndrome, which we'll talk about. I'll mention, but bear with me. That's what PCS means. So this slide is more of a nomenclature and semantics type of thing here, but it is important to talk about a couple of special words on this page, and one of them is persistent. And so it's important here to know the difference. So post-concussion syndrome can actually be diagnosed at 3 weeks after a concussion, if symptoms are still present at 3 weeks. Now, persistent post-concussion syndrome doesn't come into, isn't really diagnosed until 3 months out. So that's really the difference there. And for the most part, when we're talking about treatment and everything through this talk, we're mostly talking about persistent post-concussion patients. And I'll explain a little bit why. But also the difference here is we see the difference between syndrome and symptoms. And syndrome, I feel, classifies patients maybe unfairly a little bit, because the symptoms that come with concussion and with post-concussion syndrome, persistent post-concussion syndrome, are so unique to each person. And so when we stick a label of syndrome on someone, well, then we think, oh, they have ABC, all the way through Z symptoms, but that may not be the case. And so we might not be optimally treating this patient. So considering persistent post-concussive symptoms, we can take what a patient's telling us and really hone in on what they're experiencing, what they need. All right, so what is post-concussive syndrome or persistent post-concussive syndrome? Well, truthfully, there's no universally accepted definition. There is ICD-10 criteria and DSM-4 criteria, but beyond that, there isn't too much consensus. So the rates vary because of the unclear definition, but in general, we say that maybe 10 to 20% of patients with a mild traumatic brain injury will progress to persistent post-concussive syndrome. And so the symptoms of post-concussive syndrome, I'll get into on the next slide, but in general, they're very similar to concussion syndromes, to concussion symptoms. Notably, there is usually no complaints of nausea or vomiting after the kind of the acute concussion phase. Now, some literature does describe post-concussion syndrome as a sequelae or as a result of moderate and severe TBI. I'm not sure exactly if I, care for that necessarily, just because those symptoms that patients have are usually, in my mind, just directly related to their brain injury. Doesn't matter, not really, but maybe it does in terms of counseling, and we'll get into that a little bit. Oh, one thing to note, so this is the DSM-4 on here. The DSM-5 is the newest diagnostic criteria, but post-concussion syndrome is not in there. What it says in there is that TBIs are major or mild, and they suggest that if a mild TBI is longer than 3 months, then to consider alternative diagnoses such as somatic disorder or factitious disorder, which I think actually does a disservice to patients, because certainly post-concussion syndrome is very, very real, and we need to treat it with that kind of respect. So how do we diagnose? So just like we diagnose anything, everything starts with a history and physical, and especially in concussion and post-concussion syndrome, because these are largely clinical diagnoses. Now, imaging is in the future most likely going to become something we'll utilize more. But like we saw in the definition of concussion, which is similar to post-concussion syndrome, is that it's largely a functional and not a structural condition, right? And so the history involves asking a lot of those pointed questions. So it's very important to know the mechanism of injury to figure out if there was loss of consciousness. We need to know if there was pre or post-traumatic amnesia. Did you go to the hospital? Was there any imaging done in the hospital at the time of the acute injury? And what the symptoms have been like, and especially the time. And so if we're seeing, if I'm seeing a patient 2 days after they were hitting the head with a soccer ball, certainly my questions are a little bit different than if I'm seeing them 2 months out from their injury and they're still having symptoms. Now, some imaging can be useful if I suspect that maybe there's something else going on, that perhaps the patient did not just have a mild TBI, but maybe had a moderate or severe TBI. And so to look for any bleeding, any cerebral edema, any swelling, any hydrocephalus, various things to look for on imaging that may point to something more sinister than a concussion and post-concussion syndrome. So a lot of these symptoms are similar to the concussion symptoms, right? So very commonly, patients complain of fatigue, sleep issues, irritability. You hear that a lot. I used to be a nice, really nice guy, and I could take a lot, but I just get mad at everyone now. Mood problems, apathy, not wanting to do the things that you used to do and enjoy. Dizziness, personality changes. These are the symptoms that we're looking for, but there are also, a lot of social and work-related things that result from these symptoms, which we can talk about later. But the DSM-4 says, there are deficits in attention and memory, in addition to at least 3 of these other symptoms. So like we said, standard imaging in concussion, post-concussion, this is a CT of the head, is usually normal. So getting CTs initially, depending on the mechanism, if there was loss of consciousness, often patients do have some intracranial imaging. But, if I'm seeing a patient a few days out from, when they tripped in their backyard and bumped their head and they're not feeling right, chances are I'm not gonna send them to the ER, send them for an emergent CT scan. Every time I see these CTs, I always think they look like the Grinch. I don't know, that's me, but anyway. So some imaging abnormalities or some imaging techniques that are interesting and colorful and beautiful are on the left here is this is an MRI modality called diffusion tensor imaging. And so what you're seeing, those kind of hairy, wavy things on the back of the betta fish are axonal tracks. So they can't see the exact, we don't have the resolution to see the individual axons, but you can see the tracks that these bundles of axons follow. And so what you have on the left is a normal, normal brain, and on the right is after head trauma. And so those darkened areas are areas where those axonal tracks are not functioning or have degenerated or are certainly in an abnormal situation. And so DTI is a pretty useful or interesting imaging modality that we might see more commonly in the future. Now, on the right are just a spattering of pictures. Under D, the one with the kind of pink splotches on it. So that is DTI as well, but just not in its full glory as we see on the other side. But all of these pictures here were in patients with normal CT head scans. And so these MRI pictures certainly show a different story. What we're learning as in the medical field is that how to correlate these imaging findings with the clinical picture. How does this tie in with the patient? Because we never want to treat an image, right? We want to treat the patient in front of us. And so right now we're looking for, part of the research is to look for different biomarkers that may be a sign of impending post-concussion syndrome or even persistent post-concussive syndrome. And so if we're identifying these issues early, then we can start treatment early and maybe develop some preventative treatments for these patients. All right, so who is at risk for PCS? And so listed on this slide are a number of different risk factors, and female sex is one, increased age, extracranial injury, so other injuries besides just the head injury. As we said before, amnesia and loss of consciousness, and these can tie in with maybe a lower GCS score or a more severe brain injury to begin with. Now, multiple prior concussions is certainly a hot topic, and this is obviously in the NFL and other pro sports, they're looking a lot into head injuries and what makes someone, what causes someone to be at higher risk of having long-term symptoms or even recurrent injury. And so, we're learning more about DNA and genes, and like I mentioned earlier, that one specific gene mutation that has been found to predispose patients to concussion. I'm sure at some point we'll hopefully, find out things that are related to post-concussion syndrome and persistent post-concussion syndrome as well. Importantly, a prior history of chronic pain does predispose someone to PCS, and in part because what we're seeing a lot in PCS is exacerbation of existing pain. There's pain that creates a cycle that increases headache, increases dysfunction, which feeds back into depression and some of these other symptoms that decrease what a patient can do in a day. Prior psychiatric history is important because a lot of the psychiatric issues are amplified and sometimes unveiled through the head injury and subsequent post-concussion syndrome. Involvement in litigation comes up a lot in terms of risk. Now, I don't really know too much what to say about that, but it is a common theme. I don't know if Carly has seen that at the law firm. Okay, so what do we do? How do we treat concussion? How do we treat post-concussion syndrome? So we'll start with concussion treatment. And so the first thing that we want to do in an acute concussion is to minimize exacerbating factors, right? We want to promote cognitive rest, at least in the early stage. And so for the first 24 to 48 hours, you really don't want any really rigorous activities. And so, what I always counsel patients is to pay attention to your triggers. Now, everyone has a different trigger. One of the most common things, and what I depicted in this picture here, is the cell phone use, right? And so photosensitivity is extremely common in concussion and is a very common complaint as to what exacerbates symptoms. And so what I always tell my patients is try to pay attention to how long you can use a screen, whether it's a phone, it's a tablet, it's a TV, it's a computer, it's whatever. Pay attention how long you can use it for before you start feeling bad, right? Before you start getting nauseated, dizzy, before your vision starts getting blurry. If it takes about 10 minutes, then set an alarm on your phone to go off at about 8 minutes, right? Because we don't want the patient doing nothing, right? We want each patient to function up to a certain amount, right? A certain threshold. We don't want to cross that threshold because that's a sign that that the brain is demanding something more that we're not able to provide. And that's where that neurovascular coupling and metabolic demand is seen clinically. And so as time passes, that 10 minutes becomes 15 minutes, becomes 20 minutes. And so as the patient heals, we're able to extend the amount of time they're able to do their certain activity. So at 8 minutes, I ask the patient to then, put your phone down, close your eyes, just take a minute just to breathe and reset things and decrease your demand. And this, this principle can be applied to really anything that you're doing, whether it's driving, riding in the car, going for a walk, any of these things, even talking or having a conversation with someone. A lot of times these are the triggers for concussion symptoms. Now, some studies have shown an actual benefit of allowing kids to use their phones, to go on Instagram and watch TikTok videos. And, there are different thoughts about that, but letting them get back to their normal things have shown to decrease symptoms and decrease the duration of their concussions. Now, the old treatment paradigm used to be, lock yourself in a dark room until you feel better. We don't do that anymore, right? That's been shown to prolong symptoms and increase the rates of depression. And so we want patients to function, and part of function is exercise. And so we always promote light walking, nothing rigorous, no jogging, no bike riding, nothing puts you at risk of falling or would really exacerbate any dizziness or balance issues that you might have. I always remind patients to wear a hat or glasses when they're going out, even if they're going to go walk around Costco. Sometimes I say, you walk around the mall. Concord Mall is, aren't too many people there anymore, and so that's a pretty good place to walk. But make sure you're not exposing your eyes too much to those terrible fluorescent lights. And then diet-wise, there are certain things that we recommend to take and certain things we recommend to avoid. Now, some say don't drink too much caffeine. But if you're a regular caffeine drinker, it's not time to quit caffeine when you have a concussion, right? You're going to most likely have withdrawal headaches. So it's okay to use caffeine. Make sure that you're eating a healthy, balanced diet. You want to avoid really salty foods and things that can increase blood pressure. So omega-3 fish oils are good. Different vitamins like C, D, and E are helpful. Magnesium and riboflavin or vitamin B2 are helpful for headaches. There's kind of not super strong data about that, but a lot of people do take these supplements for headache. Now, resveratrol is kind of interesting. This is a component found in grapes and different things, and it's in wine. I'm not suggesting that you go drink a bunch of red wine, but I might also not be suggesting that, right? As far as medications go, so I would say acute concussion treatment is about 90% education and lifestyle, management and alteration, and maybe 10% medication and something else, right? And so as far as headaches go, we usually recommend your kind of your standbys, your Tylenol and your ibuprofen. Now, Tylenol has been shown more so than ibuprofen to cause rebound headaches. Usually what I recommend to patients is to alternate Tylenol and ibuprofen. Now, Tylenol certainly can cause hepatotoxicity if used or liver injury if used in too high amounts. And ibuprofen can cause ulcers, cause bleeding, and cause renal injury and kidney injury if used too much. And so it's good to alternate the medications. And so you're not exposing your body to too much of one or the other. Now, if the headaches are just really, really bad, it is possible, it's, and sometimes recommended to take both Tylenol and ibuprofen together. But it's important to keep an eye on how much each day you're taking. Now, if patients have really intractable nausea, they're not able to do any of the exercise, or not able to do the things functionally that they want to do because of nausea. Sometimes we do prescribe Zofran or Reglan or some other of these anti-nausea, antiemetic medications. Occasionally, we'll put a patient on a steroid taper or use a tricyclic antidepressant like amitriptyline to help with some of the headache and pain issues. Some like to prescribe gabapentin. I usually don't, but some others do for acute concussion treatment. So the cornerstone, the foundation really of acute concussion treatment is to avoid exacerbating factors. And that actually sometimes can include therapy. So in the acute phase, I rarely prescribe physical or occupational or speech therapy. There are a couple of reasons for that. One, because the vast majority of patients get better in a week and a half or in 2 weeks. And just by doing these minimizing things. Sometimes participating in therapy might be too much for someone. It might worsen their symptoms. And what we find is that, if you try to push through, if you just try to live your life regularly, that can absolutely worsen your symptoms and prolong the duration of recovery. As far as PCS goes, one of the main treatments is reassurance. Number one, that what you're experiencing is totally real. It's something that is, that others go through. This is something in the literature. You're not crazy. There's truly a pathophysiological process going on that requires treatment. And it's not, just, toughen up and it'll get better. That's not what we want to say to patients. But we do need to do something about it, right? And in part, when we were talking about symptoms earlier, we want to tailor each patient's treatment to what they are experiencing. Now, the different therapies, so certainly now, I send every one of my PCS patients to therapy, right? Because, I shouldn't say everyone, or maybe I'll say to a certain therapy. It depends on what their symptoms are, right? So physical therapy is super common in PCS treatment. We rely on PT for a lot of things. So for balance, so for some of these functional things, for vestibular therapy, which focuses on dizziness and the inner ear. For dry needling, usually for shoulder or neck pain related to PCS. Now, what I found a lot is that patients with headaches from concussion that that they have for a prolonged period until they're now 3 months out, they've been holding their neck in a certain way. Their posture has been different. They haven't been sleeping the same way. They haven't been able to stretch or exercise or do the things that they normally do. Well, when the muscles and the cervical spine are held in that way, they're not happy about it. And so oftentimes we develop trigger points or taut muscle bands. And these can be pain generators that result in what's called cervicogenic headache, or a headache that's not primarily, that doesn't start in the brain or in the scalp, but starts rather in the neck. And so treating headaches in a normal fashion with our different medications is not so effective for cervicogenic headache. We really have to go after the source. And so dry needling can be very helpful. Cervical therapies can be very, very helpful. Neck therapies. Occupational therapy, of course, is a cornerstone as well, in particular for some of the vision issues that we see in PCS. Massage therapy is great. If you got it, I highly recommend it. I wish we had more massage therapy, especially for the physicians at Wilmington Hospital in particular. Acupuncture and other alternative treatments can be fantastic, right? And so it's really low risk. You just have to, kind of believe it's going to work. And for a lot of patients, it really does. After that, if there are more specific issues and we need to bring on some other providers onto the team, the first one, I really should have put this first, was psychology and neuropsychology. So as we saw before, there's a lot of cognitive, emotional, psychological issues that go hand in hand with these physical things. And so psychology is really a mainstay of treatment in PCS. Ear, nose, and throat, or ENT doctors, can be very helpful for some of the vertigo issues, some of the dizziness issues. And especially if we're, maybe looking for something else, right? There could be something else going on that we've kind of chalked up to PCS, but might be something more. Neuro-ophthalmology is a special branch of ophthalmology. Now, your standard ophthalmologists, I hope there aren't any on right now. Well, anyway, no, they're great. They're incredible. They're very helpful. Their focus is on the eyeball, but neuro-ophthalmology looks at vision issues, vision loss, due to neurological issues, due to issues with the brain. Unfortunately, in Delaware, we don't have too many, or really almost no neuro-ophthalmology resources. I often send my patients either up to Wills Eye Hospital in Philly or down to Wilmer Eye Hospital at Johns Hopkins. Most go to Wills. Interventional pain can be great if we need some sort of targeted injection to help with these headaches or with neck pain. And so some of these nerve blocks can be very helpful. If you're having headache in the back of your head, the greater occipital nerve or greater occipital nerve block can be very helpful for these occipital neuralgia problems. I didn't put on here social work, but social work can be really helpful for resources, of course, to help, especially if someone's having employment issues due to their post-concussion syndrome. And so this slide's in here, just about the mind-body connection. I always say the head bone's connected to the neck bone is, connected to the spine bone. Well, the brain bone, the heart bone, those are all connected too, right? And so, if the mind isn't right, it's very hard to get the body right. And if the body is not right, likewise, it is very difficult to get right emotionally or psychologically. And so, post-concussive syndrome is a great example of how we need to take a holistic approach to treating patients. We can't focus on too much in one area. We really need to approach the entire patient. Takes a lot of time. It's a lot of hard work for everyone, but the payoff is great because we've helped someone who's oftentimes run into a lot of barriers. So one thing, as I was preparing this talk, I came across this group in Provo, Utah. It's, I won't spend a lot of time on this, but I thought this was interesting. So it's a group of physicians and researchers and different people who've spent a lot of time looking at brain injury and in particular post-concussion syndrome. And what they've developed is a kind of concierge program they call the EPIC program. So you can pay between, like $3,500 and $25,000 to go out there and choose some a la carte things for them to do for you. And what they do is they start out with a functional MRI. So they look at the metabolic demand in the different areas of the brain. Then they'll create some custom program involving these different therapy domains on the right side. And you rotate through this. It's almost like a boot camp for your PCS. And then once you're done with their program, they do a repeat fMRI and they look at what the differences are. Now, what I found interesting about this is they are using these imaging results and also with, of course, the history and the physical from the patient to try to target specific areas of the brain. And so part of their program is utilizing these therapies in a focused way. It's not the same thing for everybody. And it depends on what the fMRI looked like for each individual patient. And so, their belief is that neurovascular coupling can be improved through the right kind of activity and demand. I think it's interesting. We'll see, if some of this can get adopted in the future. Certainly it's cost prohibitive right now and travel prohibitive. You have to go out there. But maybe some of these principles can be incorporated in more commonly in the future. All right, so we've talked about characteristics of PCS. We've talked about some treatments. Now, who's doing the treatment? So we just talked about something that's not standard of care. Now let's talk about what is standard of care. And so the multidisciplinary team. And so number one, well, I'm just going from left to right. This is not number one, but the physiatrist, right? And so, depending on where you are, there may not be physiatry. So physiatry is PM&R, physical medicine rehabilitation. That's my specialty. We see a lot of post-concussion syndrome patients, right? Because really because of the dimensionality of the issues that patients have. Now, an acute concussion may come to PM&R, may go to sports medicine, or may go to neurology. But a lot of times, if the initial treatments don't produce, resolution of symptoms within that 10 to 14 day period, then these patients are often referred to us. Of course, physical therapy, we talked a lot about that. Super helpful. This lady is having some vestibular therapy done to her, that picture. Occupational therapy, very important. Speech therapy. So I haven't talked about speech therapy yet, but I do frequently refer post-concussion syndrome patients to our speech therapists, in part because they're super good, but also, to focus on cognition and memory, and sometimes as part of return to work. A lot of the patients, I have are still working and in high demand jobs, and finding that they just can't perform the way that they used to. And so speech therapy can be helpful for that, but so also can neuropsychology and psychology. And there's, again, foundational part of PCS treatment is our neuropsychologists and psychologists. Also part of the team, support groups. It helps to know that you're not alone, right? That what you're experiencing is something very real and experienced by others, and to know people who have been through it or are going through it can be very helpful and can be therapeutic in and of itself. Family. Now, family is part of the team. Family can be a detrimental part of the team, but we want family to be on board and to be very helpful. Now, that requires some education sometimes, because, while for me, I see a patient maybe for, 45 minutes or an hour at a time. Well, the remaining, hundreds of hours, the thousands of hours of that patient's life are spent with their family. And so there can be, a lot of frustration. There can be some, ill feelings toward patients, just because, these symptoms persist for so long and can really change the personality, change the attitude, change so many characteristics, so many aspects of the patient's life that it absolutely can wear on family. And so education is such a huge part of post-concussion syndrome treatment, and talking to the family, talking to partners, bring them on board. Other providers, we talked a little bit about ENT and neurooptho and different people, and also your primary care doctor. I mean, that's very important. Sometimes if you're in an area where there is no physiatry or it's hard to see a physiatrist, certainly primary care, neurology, sports medicine, they can be helpful, can be very helpful in coordinating care. So I like this quote because when I think about the goals of really anything that, and any treatment that we try to do, not just for PCS, but for anything. It says virtue is simply happiness, and happiness is a byproduct of function. You are happy when you are functioning. Now, functioning means different things to different people, but as far as PM&R, we're concerned, we want to increase or improve quality of life. The kind of, I don't know, hokey catchphrase of PM&R is that maybe while other specialties focus on adding years to life, our focus is adding life to years. And so we really want patients to optimize the what they can do that, to make them happy, right? To do what they want to do. That's the goal. And so what are some outcomes? So in general, prognosis is good. And if a patient can get into all the treatments and have all the members of the team that we mentioned earlier, then usually the duration of their symptoms is shorter, and they're able to, to achieve good benefit. Now, When I say good, what does that mean? Does that mean 100% resolution of symptoms? Sometimes, yeah, sometimes it does. Now, my goal is more so on, what the previous slide said, on increasing and maximizing function. Sometimes there is some residual deficit left over. But what we want every patient to do is to be able to function to the top of their ability within the limits of the residual illness. That's not to say we don't aim for curative treatments. We certainly do. But part of the education process is explaining that things may not 100% get to where you wanted, where you were before, but you can certainly live a fulfilling life. One thing we did learn is that extended bed rest, delayed cognitive rest, these can lead to worse outcomes. So listen to your body. That's really key. If you're getting a headache, if you're nauseated, if you're dizzy, that's your body telling you something. Don't ignore it. Don't try to push through it. So we have to ask ourselves, though, what if you're not getting better? Then what, right? Are we just going to say, well, you're one of the rare people with persistent post-concussive syndrome who just doesn't get better? Well, I don't think that's fair, and I don't think that's appropriate, and that's it's not being that's not right anyway. But what we should do is then say, well, hey, maybe we need to step back a little bit and look to see if there's something else going on. Now, the first thing, and I kind of alluded to it before, is that perhaps the patient suffered a more severe TBI than we initially thought. That concussion, whatever mechanism of injury it was initially, and we just said, okay, well, you have a concussion. Well, perhaps you didn't. Perhaps you had some more severe illness leading to cell death instead of just that cell damage. And that is why these symptoms are still here. And so in terms of treatment, a lot of the treatment may be similar, but the education, the prognosticating is different. I wouldn't tell someone with a severe TBI, hey, I think you're going to get better. I think this is definitely going to get better, to a very significant degree. I would say, hey, you know what? Like, you suffered a very severe brain injury. And so some of the deficits that you have now are likely to persist throughout your life. And so, I think setting those expectations early can be helpful for patients. And other things to consider are mood disorders, whether they were pre-existing or developed during the time since the concussion. Now, including depression, anxiety, some of the pain issues like fibromyalgia can occur as well. Real myofascial, well, I shouldn't say, myofascial pain can absolutely arise. And that's something, a little bit what I was talking about, the trigger points and the taut muscle bands. Now, that doesn't have to just occur in the neck, certainly in the back or anywhere else. You can develop myofascial pain. And that can be treated with massage, with stretching, sometimes the trigger point injections or dry needling. Headache disorders can develop, and migraines can develop in really anybody. And it doesn't necessarily have to be related to the concussion or to the time afterward. Now, often, common things being common, we say they are, but something different could arise. And then the treatment plan is different, because this is now a headache disorder that you may have for a prolonged period of time. Disordered sleep, insomnia could be related, could not be related. It may be something that just developed or became uncovered through this prolonged period of time. Where the patient is not static and is not in a vacuum for the 3 months between the concussion and when they show up with post-concussive syndrome. There's a lot also going on. Vertebral artery disease is something that is interesting, because you can get headaches, you can have balance issues, you can have even stroke from vertebral artery disease that would be missed on just a regular CT head or x-rays. There's certain specific imaging, CTAs, MRAs, angiograms that are needed to really diagnose vertebral artery dissections and aneurysms and things. which could certainly result in longer term symptoms. Now, this brings me to where imaging might be helpful. If a patient has gone through many of the treatments and seen the different team members and still not getting better, then here's where I would most likely and very often do order some more imaging, some more advanced imaging, often MRIs of the brain, just to see if there's something that we missed. So that, because that may treat our may change our treatment. Some other longer term issues related to but not directly from post-concussion syndrome are from analgesia overuse. And so we talked about with the Tylenol, with the ibuprofen. If you're using that for a long time, you certainly can cause ulcers, can cause kidney injury, can cause liver failure. I mean, if the Tylenol is used for a really long time. And those rebound headaches with the Tylenol, what I mentioned. With the inactivity that can come from the depression, can come from the headaches, can come from the dizziness. Certainly patients can develop metabolic issues. If you're not able to, be as active as you want to be, and maybe not eating as well as you could because of the these other issues that are going on. Well, certainly patients develop hypertension, diabetes, hyperlipidemia, different things, high cholesterol, different things that are not directly from the brain injury, but are very commonly associated. Depression, of course, and one thing here, is loss of employment. I've had actually a lot of patients who can't or don't want to go back to work, and so we try to treat their depression in a different way, not in a different way, in a thorough way, so they could get back to the life that they want to live. Not included on this slide is the social aspect, and this is also something very common. Patients can't maintain their same social life, and so they lose a lot of friends. They just get depressed because they can't do all the things that they wanted to do before. Going hiking or even going for a walk in the park is not as easy as it used to be. Going to see a movie is far too loud, far too bright. And becomes very difficult. And so, there's certainly a very large social aspect that we need to consider when we're treating PCS patients. All right, and so just some community resources. So of course, BIAD, the BIAD website has a lot of great stuff. Now I will say that from the professional service directory, Christiana is conspicuously absent, but I'm hoping that we can amend that going forward, possibly. The Delaware Health and Social Services website is a cornucopia of resources. There's tons of stuff on there. Really nice links and pointing you in all different directions, not just for brain injury. I mean, it's really for so many disabilities and different illnesses. And there are also some nice descriptors on the website if you find that you're looking for some language to help you describe what you're experiencing. There's that information on that website too. The American Psychological Association has an interesting feature on it in that it has a psychologist locator. So you put in your location and it'll bring up psychologists around you. And I hope I made clear how important psychology and neuropsychology is in the treatment of post-concussive syndrome. And so utilizing this resource can be very, very helpful. And of course, TBI support groups. Chances are there is a TBI support group near you or available to you now. I hadn't, not too many good things came out of COVID, but I would say Zoom and Teams and connecting virtually is one of them. And so, finding a group should be possible, hopefully. So please don't hesitate to reach out to BIAD to get connected if you need to. Just really quickly, some take-home points. And so, like we said in the beginning, majority of concussion patients see resolution of their symptoms within 14 days, 2 weeks. So persistent post-concussion syndrome is diagnosed after 3 months, but post-concussion syndrome can be diagnosed, this is according to ICD-10, after 3 weeks. And then some of these risk factors, the psychiatric and pain histories, female sex, older age. Our treatment should focus on therapies targeting the symptoms, right? There's no one size fits all treatment for post-concussive syndrome. We really need to listen to the patient, take everything into consideration. There's no detail that's too small because it may take us down the path for that patient to get them functioning how they want to. And don't go through it alone. You have a team of providers, there are support groups. There are a lot of resources out there. What you're experiencing, if you are experiencing post-concussive syndrome, is very real, is treatable. There are things we can do about it, and there are resources for you. So thank you for bearing with me for this time. This is my crack team of researchers. Here's Oliver wearing a cape. He's about to go out and either fight some crime or root through the trash. I'm not sure. And then in the middle is Cloudy. He's posing elegantly here. And then his sister Hazy, who's less than elegant but sitting like a human. And I thought that was funny. That's all I got. Thank you very much.
Thank you so much. I love the cats. You got a really great team helping you out with everything.
Thank you.
So thank you so much. That was great. That was funny. I saw the Ted Lasso reference in there. Loved that. So I got a lot of questions for you. Let me start going through some of these and let's see. So this first one, this came earlier in your presentation. If that helps you see like what the question was in reference to, this was from earlier on. Can all or any of these neurotransmitters be measured in the blood or urine directly post-concussion? If so, wouldn't that help in the diagnosis?
That's a great question. And so not yet, but there are so many avenues, and it's really too much to cover, right? But there's so many avenues of research, and finding biomarkers, number one, to diagnose concussion, and then number two, to identify who's at risk of progressive symptoms or persistent symptoms is so important, right? And there's tons of money being thrown into it, and so I wouldn't be surprised if before long there's going to be some of these biomarkers that are available. Yeah, but I don't think right now that there is anything common. There's certainly nothing commonly used right now to do that.
Thank you. All right. What are some of the advantages of using the diffusion tension imaging? What brain activities the axon track showing, and what information can it provide that the MRIs can't?
That's a great question. So there are different filters or views for MRI, for CT, to look at different aspects, different things that are going on in the brain. Now, DTI is just one of these kind of cutting edge areas that are being looked at. And so, right now, I don't think there's any clear correlation necessarily between the structural area and the clinical results of the patient, that the findings sometimes don't correlate, right? And so, and there are even, patients who have resolution of their symptoms, but still have MRI or DTI findings. And so there's a lot of research again going into it to try to put it together. And at some point, it may be something, it may not be something, but right now there are different groups that are looking into it. I don't know if I really answered your question, but as someone who's not utilizing these things on a daily basis, I'll just give you my best opinion. Yeah.
All right. Next one. Why does post-concussive syndrome affect women more and people with extracranial injuries? And how do these factors, does it worsen concussions, or it just makes it more likely that you're going to have the syndrome?
Well, so, I would say one theory, and this is not obviously, not applicable universally, but women in general may have weaker neck muscles, which results in more cranial movement. more of that acceleration, deceleration, which can cause more injury to the brain. Women are also way smarter and have bigger brains than men, so there's more to get hurt. So that I think is the real answer. There's a lot of, I mean, I can't say necessarily for sure, but there is actually some evidence of more reporting of symptoms in women, and so that might kind of skew the data in that way. But what was the second half of the question? Sorry.
Why extracranial injuries?
Oh, so since post-concussion syndrome is really a head-to-toe issue, especially when you have other injuries that can exacerbate the pain that you're feeling. You're maybe not able to do, like, let's say your concussion is accompanied with a broken leg, right? So then that'll make the the exercise aspect of it more difficult. That'll make the rehab of it more difficult. And so there are other issues that can prolong the duration of not feeling good. And so a lot of that factors in. And so really, as we saw with a lot of the symptoms, yes, there is a kind of microscopic thing going on in the brain, but the real, clinically, the big difference between concussion and post-concussion syndrome is duration. And so there's a lot that factors into extending out that duration. It's not just in the, it's not just, physically what's in the brain.
Thank you. What are some activities to avoid after a concussion?
Yeah, I mean, I would avoid anything that creates puts you in an unstable position. So riding a bike, rollerblading, does anyone do that? Roller skate, any of these, anything like that. But no, the main thing to avoid is anything that causes you to have symptoms. And so, if that's reading, if that's, listening to the radio, whatever it is, it may seem totally benign and it's something extremely common, something that you do on an everyday basis. But if there's something that is causing you to be symptomatic, avoid that activity or kind of titrate how much you do. I wouldn't, driving is one of the big things that cause symptoms because we don't think about it. We just hop in the car and drive around, but there's so much happening at one time when we're driving, right? We're scanning our environment. There's a lot of vision blur. There's a lot of stuff going on, right? We're coordinating our hands and our feet. And so, that's very taxing on the brain, actually. And so during, in acute concussion, that's often something I recommend against.
Thank you. I've got a lot more. There's a lot of a lot of questions here.
Okay.
All right. I'm just about to hit my 3-month mark of concussion symptoms. I've been doing PT and psychotherapy and will be starting speech and OT. Are there recommendations of specific support groups that may be virtual as evening driving is difficult?
That's a good question. So I would say that we can see where you are. I mean, number one, well, actually virtual, so that doesn't really matter. We can see what is available through BIAD and get you connected. I know Maggie Kalanex, who spoke a couple weeks ago, so she helps with a TBI support group, and she can be a great resource. And so she would probably have a better answer than I do. But my understanding is that she does have a virtual support group, which could be very helpful for you.
Awesome, thank you. What do you think of using SPECT scans to clarify the extent of traumatic brain injuries?
I'm going to be honest. I don't know. I think there are, there's so many domains to go into, they're diagnosis wise. I'll say this, my personal slant, and it's based upon my field in PM&R. So there are a lot of diagnostic modalities, and there are a lot of ways to quantify things. And what we find, at least in my experience, our focus is more on is really just on the patient in front of us. And so, while I did mention, with the TBIs that there may be something more going on than what we see clinically initially, but a lot of what we base our treatments on and our diagnosis on is clinical stuff. Now, of course, that doesn't mean we don't, look at labs and imaging and all these things. Of course we do, but as far as, I can't give you a great answer on what, on that aspect, but, the more we get, information we have to us and the cheaper it gets as time goes, hopefully, then, hopefully, these are all tools that we will start integrating.
Thank you. Do you think more research on concussions will accelerate now due to the popularity of professional sports such as the NFL?
Oh, absolutely. Absolutely. And so, anytime there's something very public or where there's a lot of money, then there's going to be research. And Will Smith had that movie, why, now we can't talk about Will Smith, but anyway, and so actually there's some trickle down. There's a lot of trickle down. So the research that's being done in these, professional sports is being applied in a lot of different areas. And so, there is new helmet technology. There's actually new sensors that go in helmets and in mouth guards and different things to try to, number one, detect, what causes concussions in one patient and the other. And this is more on the, of course, the, kind of like the macro view, but all of these are very, very interesting areas, and you can't just rub dirt on it and get back in the game anymore, right? Like these are these are fields that are very important. And CTE, of course, that's kind of the catch, the big thing, right? But so anyway, yeah.
Thank you. Are there any neuro-ophthalmologists in Kent and Sussex County?
Not that I know of. I don't think, to be, my understanding, and this is what I've encountered, is that there are no neuro-ophthalmologists, period, in Delaware. So there is an optometrist who does a lot of kind of neuro-ophthalmology things, but he has a super long wait list. It's, last I heard, was over a year. And so, I tell patients, beside Delaware being great on its own, we're situated very nicely, in that we're so close to Philadelphia and, relatively close to Baltimore. And so we're right in between what some consider the second best and third best eye hospitals in the country. And so there's a lot of, there are a lot of providers there. What makes these hospitals so good, when you go to those top places, they don't just have one guy who's a specialist or an expert in what you're looking for. They have a whole roster, right? You have, 6 or, however many people you can see. And so that is what I recommend. I know from, Southern Delaware, it's a long way, I know. But it might be worth it. I don't know what they do, and I feel like virtually is hard for this kind of issue. But that's almost the best we can offer right now, I think.
Okay. Do people ever fully recover from post-concussion syndrome?
Oh yeah, most do. Yep. The large majority of patients do. I will say that if issues are left untreated, if they're left unrecognized, then sometimes patients still do get better. I mean, the brain is remarkable. I mean, the plasticity of the brain can heal. We don't grow new neurons, but things can heal, and the healthy areas can take up function of the injured areas. And people, the vast majority of patients get better. Yeah, for sure.
Awesome. All right, I've got 2 comments. Let's see. Oh, no, but I got another question. What is the time range for recovery of post-concussion syndrome or post-concussion symptoms?
Highly variable. So it depends on the person. I would say the earlier we can diagnose those symptoms, and the earlier we get into treatment, the sooner the recovery would be. And so the majority of patients are better within 12 months. And so, just putting a number out there, But that again depends on when the diagnosis is made. I've seen patients who are over a year out from their injury and still having symptoms. And so certainly, those patients don't fall within that 12 months. But, if we're, the ideal scenario is you follow a patient from their injury and then follow them through their course. And if they do develop post-concussion symptoms, then, then you kind of change your treatment paradigm and start addressing that. But I will say that in the Christiana system, at least how it used to be, I don't do a lot of outpatient anymore, but when I was, the majority of acute concussions were seen by sports medicine or by neurology. And then, we would kind of, PM&R, we kind of get the patients who aren't better yet after a number of months. And so, it really varied based on how long that patient had symptoms for. But again, the sooner you're seen, the sooner we can get you in the right treatment.
Great, thank you. I think I got several comments for you. Awesome presentation. Thank you, Dr. Cheng from Center for Rehab.
Thank you.
Miss
Oh,
D.
you're welcome.
She said, this is a very informative presentation. It was much appreciated. Thank you.
Thank you very much.
And Miss Moon said, thank you for helping us folks with these challenges. She says she's healing from PPCS.
Oh, okay.
Very happy you're here to hear all of this then.
Yeah.
It looks like that is everything so far. So, okay. So thank you again so much, Dr. Cheng. That was fantastic. It was hilarious. It was informational. Very much enjoyed that. So let me turn it back over to Zawaya for a few minutes. She's got some follow-up reminders for everybody.
Thank you, everyone, very much. I appreciate your time. I know it's not easy. Thank you for listening to me, and I hope it was good. Hope everyone had a good evening.
It was excellent, Dr. Chen. Thank you.
It was. So thank you so much, Carly. Thank you, Dr. Chen. I am going to make this quick because I know I want to respect everyone's time, and we're a little over by 3 minutes. But I want to let everyone know that I will be sending out a follow-up email at the end of this session with Dr. Chen's presentation and information on the BIAD events that we have planned in the month of March, because March is Brain Injury Awareness Month. And I would like to invite all of the participants to show your support for our community by wearing blue for the month of March, and to also attend. We have a virtual event that will be sponsored by Dr. Haresh Sampath Kumar and his practice, Delaware Neuro Rehab. This event is free and open to the public, but you will need to register. So if you send me an email at admin@biad.org, and I will be sharing a flyer with everyone that's on the presentation tonight. I will send a flyer out with the Dr. Chen's presentation, and I will also send a link that will allow you to register. And for those of you that are needing CEUs, I would like to share the CEU with you. It is, okay, I'm going to stop. I'm going to take over for a minute, Dr. Chen.
Yeah, and I'll stop.
So it's fine. So if everyone can look and see, it is 2023 BIAD, hashtag 2023 BIAD.
Right, okie dokie. Thank you guys so much. We're back here again on the 30th, 6 to 7:30. The topic is long-term effects, health effects after traumatic brain injury. Dr. Dawn Tartaglione from Bay Health. It's going to be amazing. So thank you all so much for joining. I'm so happy everybody was here tonight, and we'll look forward to seeing you next week. All right. Have a good night, everybody.
Thank you. Good night.
Right.